Hello everyone and welcome to today's webinar, Reducing Errors and Enhancing Compliance, a practical look at digital workflow in blood gas testing. I'm Cassie Saltman of LabRoots and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Radiometer. To learn more, visit radiometer.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. We will also have 2 interactive poll questions during the presentation, and we strongly encourage your participation and appreciate your responses. I'd like to now introduce our speaker for today's event, David Gibson, Respiratory Care Sleep Disorders Director. Mr. David Gibson is a seasoned healthcare leader with over 35 years of experience driving excellence in healthcare operations. He brings a strong track record in team leadership, performance management, and cross-functional collaboration to implement impactful processes, improvement initiatives that enhance operational efficiency and organizational performance. For the past 27 years, David has held leadership roles across various clinical departments, including serving as the administrative director of both the clinical laboratory and respiratory therapy. David holds an MBA from Liberty University, along with a Bachelor of Science and a bachelor's degree in business management. David, I will now pass it over to you for your presentation.
Hey, thank you very much, Casey. Thank you all. It's a true opportunity and greatly appreciative to present to you today. I'm going to start off with the simple generic disclosure. This content of the presentation is intended for educational purposes only. The perspectives I'm going to share today are based on my own personal experiences and anecdotal observations. This session does not present controlled studies, comparative data, or before and after measurements. While I am going to provide some useful information and insights, the information shouldn't be taken as definitive evidence or universally applicable conclusions. I would also like to note that I have no conflict of interest to relate to the content or context of this presentation. So with that said, we're going to jump into a first poll question today. If you would participate with this, the first question is, how often do patient sample mix-ups or misidentifications occur in your facility's blood gas testing process? So again, if you could, you'll see rarely, less than once a month, occasionally, a few times per month, or frequently, which is weekly or more. So again, if you could answer this question, that will help us, and you'll see how this relates to today's topic. How often do patient sample mix-ups or misidentifications occur in your facility for your blood gas testing? And we'll just, I'll just refresh my screen until I see this plateau. Getting a lot of responses. Thank you very much for responding. Give it just a few more seconds. Okay, looks like everybody's pretty much there. Quite a bit. Overwhelmingly, we're seeing that we all deal with the same thing. So thank you very much for your participation. We will have another poll question towards the end. So with that said, I want to jump into the presentation today. Today's objectives are to discuss improved accreditation outcomes. Whether you're talking about Joint Commission, CAP, CLIA, any of us who work in the lab or blood gas laboratory, we understand accreditation is a key part of what we do, of who we are, and the quality that we provide. We're also going to discuss improved patient sampling accuracy, which includes patient data. We'll discuss reduced pre-analytical errors and discuss how integration of new technology has made an improvement for the organization that I work for. Now, this integration and this improvement also includes patient and staff satisfaction. Coworker satisfaction is key. And coworkers have to be able to trust the devices that they're using. We'll discuss quite a bit about the occurrence of pre-analytical errors and again, staff confidence. So later on in this presentation, I'm going to refer to a study that was conducted in 2024 by Gonzalez and Cuiditos, and it discusses specifically pre-analytical phase has the highest percentage of errors, which was around 65%. So we're going to spend some time today talking about how this new technology that we are using helps greatly reduce pre-analytical errors. So a little bit about me and about the organization that I work with and for, Saline Health Systems. You can see that we have a high quality on focus. We are a Leapfrog A hospital. We are accredited in the laboratory and in the hospital setting by a joint commission. And also chest pain registry. Our clinical lab is very strong, and we have several Joint Commission CAP inspectors there as well. We have several clinics. Our services on the next slide you'll see include cardiology, primary care, surgery, weight loss. But again, we have a high focus on quality. And a little more about our services here. We have a 16-bed acute rehab facility. We're roughly 177 beds. We have a very strong labor and delivery unit, very busy surgery area, as I'm sure most of you are busy as well in your surgical suites. Cardiology has a strong presence. Orthopedic care, again, is a key marker of who we are as an organization. Bariatric weight loss, I would say that we are the #1 bariatric weight loss facility in Arkansas. And again, Wound Health and Healing Center, very strong and accredited sleep center. So everything we do as an organization, the #1 focus is on high quality. We do a number of quality assurance process improvement initiatives throughout the organization. We present that data, we track it, and we're very systematic in what we present and we track. So let's jump into the realities that you and I face today. Hospitals are busy. I think you would all agree with me. The reality is we're probably too busy. We face a lot of different issues or encounters day to day that sometimes it makes life difficult. One of those things that I dealt with in the past was manually tracking my quality control. We had a homegrown system that was interfaced, and it was tough. It was tough not only to access, but it was tough to extract data from. The second thing was sample mix-ups. Sample mix-ups was one of the problems that we would encounter. And unfortunately, I think we all, as our poll question indicated, I think we all deal with that on a regular basis. And sometimes these sample mix-ups go undetected until it's too late, and then it really gets labor intensive. We're also going to talk about label-based ID workflows and how those are vulnerable to human error. Regulatory pressures, demands traceability and documentation. But our staff, we get overwhelmed. So staff members must be confident in their instruments. We have to be confident in our processes, in our workflow processes. The fast-paced environment that we work in today in the laboratory, it makes it tough. And yes, we do have some processes in place, but you all know as well as I do, when we get busy, processes, they fail. And humans, we are going to have make mistakes. We're going to have error. I mentioned earlier that our previous data management workflow was homemade. It was no systematic processes, very manual QC process of tracking, time consuming, error prone, no real structure. And so I mentioned earlier it was okay. And it was just okay. It checked the boxes. But the reality is I had to realize that I'm limited in how much I could safely do. and how much my staff could safely do. Not to mention the human error piece is much more prevalent than we would like to admit. So having or using a system that's robust, that's automated is key. If we're going to create systematic workflow processes that work for providing better patient results, better patient care, more consistency, I knew we had to transition from a homegrown system to something that was robust, something that would give me insight that I needed. Again, you think it's easy to take 2 standard deviations for granted until you calculate them. And it's easy to take control percentage variation for granted until you're the person who's calculating that. So to get any meaningful data, it would take me 2 to 4 hours simply to run reports. That didn't have anything to do with the amount of time that it took for me to calculate the data manually. So patient volume, so you have a little insight about us. We do around 1,000 samples per month. If you've ever managed an analyzer, whether it's a blood gas machine or a chemistry machine, it doesn't matter what, you have a number of things you have to do to keep your machine up and running, to meet the Joint Commission standards, to meet CAP or CLIA standards. Some of these things include QC correlation studies, routine daily QC. We do QC 3 times a day. Since we have oximetry, we do 2 levels since it involves hemoglobin, 2 samples 3 times a day. Proficiency testing and reporting is quarterly, CAL verifications every 6 months, blood gas correlations, monthly reporting for accreditation. And again, the list goes on. I wanted to add this slide to demonstrate one key point to anyone who may not be clinical laboratory. Having a machine is very time involved. It is very invasive. There is nothing easy about maintaining an analyzer. And in fact, the fewer analyzers we have, the easier it is to meet accreditation standards, because everything that's mentioned on this slide takes human time. And it also makes us more prone to errors. So not to mention, it also increases our costs greatly. So patient volume is key, but so is understanding how much time and effort it takes to maintain analyzers. So our goal is to discuss how do we move from risk to control. Now, it doesn't matter if you work in a respiratory therapy department or the clinical laboratory. We need to be able to move to integrating hospital systems that are intuitive, that work for us. I have a rule that whether it is, regardless of the computer system that I'm working with, no more manual processes. It is time to move from a manual process to an intuitive process, a system that works for me, that calculates for me, a system that I can trust. So that's what I mean when I say moving from risk to control. So a question that I have for you to consider as we're presenting this specific slide: have you ever used that system that you just thought to yourself, this is too difficult? It's too difficult to navigate. Maybe it was too easy to make an error. Maybe it was homegrown. Maybe it was a vendor that just wasn't very robust. It's frustrating. And if you've been the clinician on the bench top, you understand those frustrations. And again, I come back to my key point. Computers are intended to make our lives easier, not more stressful. So for any respiratory therapy departments or clinical labs systems, instruments that allow for real-time data to drive outcomes, that's what we're wanting. That's what we're needing. We need these automated alerts, bedside scanning that can help reduce patient sample mix-ups. We need devices that can reduce pre-analytical errors by systematically mixing our samples for us. And we need to help manage, help managing all the information and data. You know, I'm sure you've heard your Joint Commission inspector say data overload or data paralysis. You know, we need help managing all the information and data that's gathered, and we need help formatting this into reports that's meaningful. Our accrediting bodies, they don't just want numbers or data. They want to know that we're incorporating this data into QA/PI processes that make improvements for our patients, for our laboratories, for our organization. So the question is what are you doing with the data that to make improvements to drive outcomes for your organization? I speak a lot on leadership development and leadership growth. And this same question is on there. What are we doing to drive improvements with the data we have? Having all the data in the world is useless if we're not using it, incorporating it in real time to make improvements. So our goal is to move from risk to control. And current data management workflow, you can see on this screen, you'll see a picture of the analyzer we currently use. What's integrated into that, you'll see the middle part of this slide is a cure. That's our actual data management system. And that flows into our EMR. We have two EMRs here, Pisces and Allscripts. It is a streamless QC audit trail. The inspection process is awesome. Our Joint Commission inspectors love the product that we have. So our current data management workflow process is big impact. There's no external computer to log into. And while you may say, hey, David, that's not a big deal. It's a big deal for me. It's a big deal for my staff because they don't need to access a next step. It's all about simplification. And that's the core of simplifying processes or systems to get them comfortable quickly with accessing data and using the data management system, looking at the data, looking at the patient's historical data, reviewing the QC and the blood gases, trending those out easily without accessing another PC. So having a robust data management program, it should result in our team members having confidence in their instruments and in the data management system. So for reference, again, this picture demonstrates so you can visualize our workflow process. And so as we move forward in today's presentation, you'll see two things. Our Accure data management system on the left, the Accure system is built into it. Now that's an ABL 830 blood gas analyzer. It's a benchtop analyzer, very dependable, it's a workhorse. And you'll see what I mean by that in a few slides. So we have no external computer to log into. Everything is built into the analyzer, and the analyzer itself and the database are combined into one product, which allows the clinical staff to navigate very easily. You simply tap into the analyzer with your name badge, and boom, you can run a sample, or you can simply log into that analyzer, scan in, and you can review the QC just that easily. So how do we go from manual QC tracking to peer QC? It's earlier in this presentation, I mentioned the need for analyzers to work for us. This includes monitoring trends and outliers, anything that may impact testing. So when Joint Commission shows up, the inspector is going to look through all of your data, but they're also going to want to know what you did as a result of if the QC failed. And I think we all agree that working in the laboratory, we need peer review comparison tools that allow us to identify trends in real time. So here's a great example. So after logging into the system 2 days in a row, a couple of months ago, I noticed my peer comparison was populating in my daily issues tab. This gave me insight into a problem that I didn't know I had at the time. While my QC was passing and while the cows were passing, everything was good, but my peer review, the computer was saying, David, it's passing, but it's a deviation from your historical data. So I was able to identify that my coax was starting to have some fluctuation. And when I called tech support, they logged in from where they're at and said, hey, David, yes, you're right. You are starting to have some fluctuation. They logged into my oximeter. They diagnosed the issue. And they said, you know what, we're going to fix your problem before you really have a problem. Tech support's on their way. And I thought, right, sure they are. Less than a day later, I have a guy show up. He had told me everything that was going on with my oximeter. And he said, I'm going to replace this part. So that's what I mean by having your analyzers, your equipment, or your computer work for you. My co-oximeter was at the beginning of having issues. But again, I want to stress this. My QC was still passing. My peer-to-peer tab was what gave me insight. It gave me real-time trending that, hey, David, you want to get this checked out. So instead of having downtime, which we all hate, I had time to call service, get somebody on site and fix it before it became a headache. And again, that's what I mean. When I talk about transitioning from systems that don't work for us to something that is going to ensure accurate, reliable results, we got to get past checking the box. And that same thought process must include analyzing our QC. So on this slide, you're going to see something unique to the world of blood gas testing. With our new setup, we're able to analyze up to 3 samples in our tray, each with its own specific unique barcode. So when we sample at the bedside, we will go up to the patient, we'll have our order, it has a barcode. Our safe Pico syringes have a barcode. We scan the we will check the patient identifier, their barcode, their name, their patient identifiers, and then we scan at the bedside. We'll scan the order, we'll scan the syringe, and at the moment when we scan that syringe, it connects the dots. We will enter the information for the patient at that moment at the bedside using a module called FlexLink. And so at that point, we are tagging the actual syringe. Now we do go ahead and place the label on the patient sample per Joint Commission. But a great safety feature here is once I scan that syringe with a barcode, that sample is also labeled, and you'll see the benefits of that shortly. So when we bring this sample back and we put it into this tray you see on your left where the 3 samples are, it scans it, it tells me, and it populates into Accure who my patient is, the settings that I entered at the bedside, and it auto mixes that. So this really highlights the value of integrating FlexLink and FlexQ tray. So in a second, we're going to look at the next slide to demonstrate the value of why that's so important. But again, I mentioned earlier, these machines allow us to analyze up to 3 blood gas syringes in the tray at a time. This helps us avoid confusion over sample mix-ups. And I hope to communicate and convey just how that has helped us over the last few years. So sample mislabeling, we hit on that. Mislabeling is tough for all of healthcare. High stress environment, high volume atmosphere, using a laboratory reporting system with these built-in safety rails that I just mentioned is right on target. It's what we have to have. It's so easy to pick up the wrong order and scan it, and then bam, you've got the wrong information. So since we have transitioned from our old system, our old process, to this new system, we've had 0 samples mislabeled. That's because we scan at the bedside. That's because we scan the order at the bedside. We enter the information in at the bedside. The syringe is tagged, it is labeled, and when we lay that syringe down, we have our order in our hand and we can say, look at that. It's pulled up our patient information, it's pulled it up very well, and we correlate it with our order and we double check it. So this example demonstrates how much, how valuable this tool is. And I didn't hit on it very much, but if you look at the bottom of this slide where I have example, it says example, routine sampling requires staff to write down and remember a lot of stuff, right? Oxygen settings, ventilator settings, the FiO2, the liter flow, the tidal volume, all of this information, respiratory therapists at the bedside are having to try to remember all of this information. This demonstrates how much we have to plug in. With this system, we don't have to worry about it. We plug it in right there at the bedside. So before we had to write it down, trust our memory. plug it into the homegrown data management system. And it was difficult. And again, we may have 10 to 20 patients on a ventilator. That's a lot of information to remember and to try to segregate out. So the FlexLink system, it allows us to enter our patient information right there at the bedside. And as you can see, there's a lot of information, but when we scan that blood gas syringe, it pulls everything across. It's eliminated not only the mix-up process, but it eliminates our failing memory or our overwhelmed capacity to remember every single detail that the patient was on. If I tell you the patient was on 60%, 550 tidal volume, respiratory rate was 28, but they were breathing 32, the PEEP was 8, and the mode is assist control, that's a lot for a person to remember. Now imagine having 10 patients on 10 different ventilators. That makes it really difficult, and it makes you more prone to error. And so that's a key for me. When I talk about my organization being high quality, that's what I mean. We have systems in place that help us not only ensure we're getting the right patient, but that we are also getting the right information that may impact patient care down the road. Because if I enter FiO2 liter flow PEEP device, if I enter that incorrectly, then what I've done is I've compromised my patient's care. So reducing pre-analytical errors is what I'm talking about. And, these analyzers, it not only identifies the patient that we have tagged in there, it also mixes the sample itself. So as many of you know, pre-analytical errors are real. And according to this review that I discussed earlier, Gonzalez and Cuiditos, pre-analytical phase, up to 65% of errors are pre-analytical in nature. And this indicates that the pre-analytical phase is the most error-prone stage of lab testing. So in this presentation, we're really focusing on how to bring that percentage down. And the FlexQ tray that you see on the left, where the samples are placed in, it mixes that. There's actually a metal BB in there. You lay the sample in there, it scans it, populates the information on the left side, and it begins the process of mixing. So anyone that's ever ran a blood gas, you've encountered one thing I'm sure of, and that's a blood clot. So there's nothing more frustrating than you have a patient that you had to talk into getting a blood gas, and they said, you got one chance. And so you stick them, you get it, you're feeling really good, you put it in your analyzer, and the sample is clotted. So this is awful. And at the onset of this webinar, I stated we need systems that help work for us. This FlexQ tray does that. It may not be a big deal to you, but again, we've had 0 blood clots from our FlexQ trays, and that's huge to me. In addition to, the patient being unhappy, they don't want to be stuck again because their blood clotted. You also have a frustrated and unhappy staff member who now they got to go back and stick the patient again. But not just that, now they have a blood clot they got to fix. And if you've ever worked on a blood gas machine, that's easier said than done. Blood clots in the world of blood gas testing are awful. And encountering a blood clot wastes staff time and resource. Not to mention, it really does frustrate the clinician who's responsible for that analyzer. So hospitals, laboratories, respiratory therapy departments, we need analyzers again that are intuitive, that help us, that help reduce blood clots, that help reduce patient sample mix-ups. And another key point is the cost associated with running multiple analyzers. Earlier, I told you we analyze 600 to 1,000 samples per month. And that doesn't include, and that's costly to keep that machine up with the reagents. So there's a real supply cost and staff cost that we have for every analyzer. When you have a FlexQ tray that you see here on your left that can analyze 3 samples without any mix-ups, you really streamline your workflow process. And if I have this one machine that can do the work of 3, then I really do cut down not just on cost for sample or for testing, but cost for reaccreditation for each analyzer. So the FlexQ tray has just been fantastic in identifying in mixing the sample, the FlexLink, in scanning the barcode to avoid confusion. I can't tell you how much time, I can't express how much time I've saved by not having to fix an analyzer with a blood clot or fix a sample that was resulted on the wrong patient. So we all focus somewhat on accreditation, right? It's a key part of who we are. If you work in the laboratory setting, you know accreditation is always a hot topic. So as we begin to wrap up the end of this presentation, I do want to hit on a couple of key points that are related to preventing accreditation failures. And that's been my experience. So in a recent survey, we were asked to produce 2 years worth of critical results. So if you've been surveyed recently by the Joint Commission, you know they're saying, show me your critical results. Show me your response. You're monitoring this. I came back to my office. It took less than 30 seconds to access the data. I printed it out. And again, you could imagine 2 years worth of critical results. It aggregates the data for you. It breaks down the average turnaround time. It demonstrates any outliers, any failures you have. And I print this out. I bring it back to our accreditation room. And the Joint Commission inspector said, "You're kidding. You just ran this report." I said, "Absolutely." They looked at my laboratory team and said, "Why can't you have something like this?" I felt bad, but I also felt great. It's not the fault of the clinical laboratory, but again, they were being forced to use a homegrown system. That's why I really have to emphasize, if you're using a robust system that works for you, man, it really does make a big difference. Now, I want to focus back a little bit on the bottom part of this slide. Preventing accreditation failures. This system that we use does have a stoplight and a lockout. So if the machine is in a red or a yellow condition, if you work with respiratory therapists, you know sometimes we will try to run a blood gas when we shouldn't. This system prevents that. It is awesome. It has the integration of technology which prevents errors, like we mentioned before, reducing clotting. There's also another key aspect on here, sample repression. So if you have a value that is erroneous, that it questions, it will simply repress that value so it is not reported. So lots of hot topics for accreditation for Joint Commission. But again, a key I do want to hit on is critical results reporting. You need to be able to demonstrate that you reviewed these critical results and that you're aware of them. This system does that so easily. I kept thinking, what else is there? So a great tool, great part of the Accure system. It makes it so easy for me to use and to navigate. And I wanted to include a snapshot of that. So this slide is simply a quick visual of how easy it is for us to access and to monitor our critical results. I choose 10 minutes. You can actually choose 10 or 15 minutes for critical results. Typically, the only failures we see in our reporting are with new graduates who are new hires and they have trouble navigating their own time frame. They don't understand the importance of it. Afterwards, I meet with them and I educate them on the importance of them being timely. So it's a great visual representation. If we do have outliers, it's typically because they have entered the time incorrectly, or they have simply gotten hold of some poor practices. And this really does help me monitor them because it will tell on them. So summary today, when we started today, I talked about acknowledging we're busy, sometimes too busy. and we're consistently expected to do more with less. Providing excellent, high quality, and safe care in a fast-paced setting, it demands analyzers and programs and systems that work for us, that work with us on every level. So the pre-analytical phase, we've demonstrated that that's where most of the errors are occurring. That's why it's important for us to employ systems designed to reduce risk, improve safety and quality, and ultimately improve both patient and coworker satisfaction. When you have a system that's robust, that's automated and reliable, that reduces blood clots, that's what it's all about. As humans, we're naturally going to be limited in how much we can do. And the reality is we all make mistakes. It's inevitable. But when we have a strong analyzer and an intelligent data management system in place, we can give our team members the confidence they need to perform at their best. We have to have tools that operate in real time and drive better outcomes. Having automated alerts, bedside scanning, systems that mix the sample for us systematically, reducing clots, reducing cost, reducing frustration. There's an old saying, control the controllables. In the past, this wasn't a controllable. Well, now it is with the system that we use. It's the difference between night and day. And that's how we take control. Healthcare, we know this. You can attest to this yourself. It's not becoming less complex. It's becoming more demanding every day. And that's why we have to invest in systems that alert us before the problem occurs. Earlier, I told you the story, the example about the machine, the analyzer told me I had a problem before I knew it. That not only boosts the confidence of the respiratory therapist or the clinician, it boosts my confidence because I know I have a machine that's going to communicate well with me. So at the end of the day, regardless of what system you're using, it's all about success. Everything I've discussed today comes down to one goal: providing accurate, timely, and actionable patient information so we can manage patient better, faster, and safer and more accurately. So most managers today have to think about the cost of managing. I've used systems in the past that are point of care. I've used systems in the past that are cartridge based, but those are all associated with a higher cost. And the data management system simply was not nearly as robust as what we're seeing. So I want to wrap it up before we open up into questions. There is another poll question here. If you would participate, do you feel your current middleware supports your needs effectively? Answers are yes, very effective, somewhat, but there are gaps, or no, it's a challenge. So if you could participate in this poll question, do you feel your current middleware supports your needs effectively? And I'll pause while you complete this. And Casey, I see they are participating in this, and I will turn it back over to you for any questions and answers.
Yeah. Thank you for your informative presentation. So we will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just type your questions into the Ask a Question box and click Submit. And we'll answer as many questions as we have time for today. Our first question asks, when you say peer, do you mean QC data from peers at different hospitals?
When I say peer, there's two options. Whatever's in the peer database, but typically no, I'm comparing my peer to peer compared to my historical data.
Okay, understood. Thank you. Next question that we have is asking, how are you scanning your samples? Is it with a hardwired computer in the room or a handheld device?
It is with a hardwired computer in the room, and the barcode scanner is tethered to the computer that's in the room.
Perfect. Next question that we have here is asking, how does this FlexTop prevent blood clots?
Okay, great. So when you use a safe pico syringe and you insert it into the FlexQ tray, it begins the process of mixing, and it will mix. It's a, for lack of a better word, it's a metal BB type object inside of the blood gas syringe, and it thoroughly mixes that sample. And that, again, that has made such a big difference. When I say we have had no blood clots when we've used the FlexQ tray, I can't tell you how important that is to me because it saves me so much time. But the tray itself activates and it begins bouncing the metal BB all around inside of the safe pico syringe.
Wonderful. Thank you. All right, next question here. In your facility, who maintains your ABL analyzers, POCT, RT, or biomed?
Respiratory therapy, I do. I manage those, maintain those myself, do the CVMs, do the proficiency surveys. Now, of course, the maintenance on it's very minimal and it's very easy for me to do. But we do have radiometer do, of course, they do the big PMs that are required on there, but respiratory therapy maintains the analyzers itself.
Okay, thank you. This next question has, it looks like 3 questions rolled into one. So I'll ask the first part and then we'll move on to the second part. First part of this is, at which point in the workflow does mislabeling usually happen? For example, collection, labeling, or transport?
I think it's on the backside of collections, because in the past, prior to FlexLink, it was so easy to grab an order that was wrong and they go to the wrong patient and they don't realize that until they're on the back end of that. Now, the beauty of this, what's resolved that, is when we go to the patient's room with the order in our hand and we scan the barcode, when we bring that sample back and we put it in the FlexQ tray, it populates. And again, it's simply another step of safety that helps us say, right patient, right procedure, this is it. So it could have happened at any phase. Typically, it's going to happen on the beginning or the back end. That's where most errors were happening.
All right, perfect. Part 2 of this question, what indicators are used to identify that a blood gas sample is clotted?
The machine will actually tell you that the system is clotted. No sample detected. It will give you a number of different errors that will tell you that it's the sample is clotted. And again, it's not unusual in the blood gas world, especially if you work in the neonatal world. You know that fetal hemoglobin has a high chance of clotting. So the analyzer itself will tell you that the sample is clotted.
Excellent. So that would tie into question 3, which is, how is feedback communicated when a clotted sample is identified?
Yes. And again, it's awful. It just takes so much time, and it really, when you're busy and you're overwhelmed and you're trying to get to the next patient, when you have a sample that is clotted, it takes your machine out of service. It requires someone to come and to unclot the machine, and it uses your resources again, your blood gas syringe again, your clinician time again. So it really does make a big impact.
Excellent. Thank you. Our next question here is asking, how does your staff handle barcoding in the room when a nurse is using the computer?
We have cows. I think we all are in the same situation for the most part. We will typically take a cow with us if it's needed, and it's loaded onto our cow or onto our tablet, and we can just take our little tablet into the room and scan that way or log in that way.
Simple. Okay. Next question here. Does the collector still mix before putting on the instrument?
Oh yeah, we still go through the same processes. We'll still roll the sample. We'll still place the sample appropriately. Absolutely. We still go through the same processes, just because that's what we were taught to do. But once you see this mixing tray in action, you will say, "Aha! This is why it this is why David was bragging on it so much. It is just incredible technology."
Excellent. Thank you. All right, next question here is asking, when you enter the patient data, such as sample, sample site, Allen's test, drawn by, is that all entered at the time of collection and populates the EMR?
Yes, it's all entered at the time of collection. However, it's not transmitted to the EMR until after the sample is analyzed and accepted. You have an option at the end to accept or to reject after the sample is analyzed. And at that moment, it immediately transfers over to the EMR.
Wonderful. Okay. Our next question here is asking, can you put venous cord gas and an arterial cord gas in the tray at the same time?
You can. This process is the same again. You can put any type of sample in the tray, arterial, venous, mixed. And the key is scanning the sample at the bedside, which labels it, and entering the information into a cure in FlexLink at the bedside. And you can have 3 different patients from 3 different rooms that are scanned in. And again, that's the beauty of the FlexLink tray. It does all the hard work for you.
Excellent. Thank you. Okay, next question here. How did you transition from a manual QC process to an automated system without disrupting daily operations?
It was a lot easier than I had thought it was going to be. Once we got our system up and running, I couldn't believe how easy it was for everyone to pick it up and for me to use the data management system so easily, especially without a computer. Without a computer, in my mind, I was imagining, oh, this is going to be awful. Oh, it is. I mean, again, the machine, the analyzer itself submits all of the reports. I don't have to do anything. At the end of the month, it submits the reports for me. I log in on my PC in my office, access the reports, print it out. The transition was very smooth, very easy, only because if you've ever used a homegrown system, you know those are very labor intensive, time intensive. And when you use this device, you really do see how much time you're saving. Staff time, super easy, especially with analyzing the sample. You log in, you've registered your sample at the bedside. You put your syringe in the FlexLink tray, and it does the rest. It's a very easy, very smooth process.
Wonderful. Thank you. All right, next question here. What steps did you take to get staff buy-in for adopting a new technology?
I think really it was just showing them they knew our old processes. They knew how difficult they were. They knew um, the challenges that we were currently facing. So just demonstrating that this technology, and again, it took time. We had to prove it. We had to demonstrate that this is really going to reduce blood clots. This is really going to label itself at the bedside. After everyone did one sample, they saw how easy it was. I've used some very difficult laboratory analyzers and very difficult point of care analyzers. Once they saw how reproducible, how easy this data management system was, and how easy it was to use the blood gas machine, I mean, this is this is the easiest machine that we have to train people on. Just because once they use it once, we're like, you used it once, now you got it, and they do. Our new graduates, super simple for them to use. And again, if Joint Commission were to walk in, they could walk them through this very easily because it's that easy for us to use.
Okay. Well, speaking of training, our next question is asking what challenges did you face when training staff to use barcode scanning at the bedside?
We were already familiar with barcode scanning with our medications. So the true training was to say, scan the syringe, scan the syringe. It tags the syringe, um, and then just having the understanding of the process. But um, that was a little difficult. And when people see us scan a syringe right now, they look at us, our Joint Commission inspectors, when they see us scan a syringe, they're like, "What are you doing?" And so we say, "Look, this is a backup feature. It's not really a backup; it's our primary, but this is just an additional feature that ensures that we don't have any patient sample mix-up." So just demonstrating, "Hey, look, you scanned the syringe." Was it a challenge? No, it was super simple. But it's one of those things that we do get questioned about quite a bit because I don't see anyone else scanning syringes.
Very good point. Okay. Next question here. How does the system handle connectivity with EMR and ensure traceability for accreditation purposes?
Integrated very easily. Actually, on the machine itself, you can see if it ever becomes disconnected. So let's say that we're doing an upgrade in our EMR. You will see a little snowflake on there that tells us that it's disconnected. Integration is super easy. We again, if you know me, you know I hate computers. You know I absolutely hate them. But the integration process was very simple. We use Pisces and all scripts. And so the integration process, even whenever it's down, we're still able to access. We go to a downtime process, but then when we come back up live, all of our information is there, the data is there, and we simply transmit the data over after the EMR has came back up. So it's a very easy process to integrate. And again, pulling data from, wanting to demonstrate to your accreditors, very easy to do. It's if you've ever pulled out, when you go through an inspection and you have all the lab manuals, you've got all your, this is very easy to get any data, extract any data that you need to demonstrate we're not only having a policy for it, we're actually doing it.
Wonderful. Thank you. And we have time for a couple more questions here. So this next one is asking, since implementing these systems, what measurable improvements have you seen in turnaround time and staff satisfaction?
Staff satisfaction has been huge. We measure staff satisfaction for the last, I would say, easily 10 years. Our staff will be the first ones to tell you the importance of having that mixing tray, preventing blood clots. Turnaround time, currently, our current turnaround time is 4.2 minutes. And that's fast, right? We only have 2 analyzers. And the reality is we only need 2 analyzers. If we're doing 1,000 samples a month, that's not a low volume, but turnaround time is fantastic. That's something that I monitor. I have a QAPI for that I monitor each month. So it works great for us. Turnaround time is great. And again, the reports are unbelievable. Anything you want to measure, any QAPI processes, it really does help you set a good baseline and monitor where you're at. And sometimes in the past, data was difficult to extract. With this system, data is easy to extract.
Excellent. Thank you. Our next question is asking, are there any issues with IT allowing a cure to send information for peer reviews?
Is there any, read that question one more time.
Any issues with IT allowing a cure to send information for peer reviews?
Oh, no, not at all. It's integrated to, there are 2 peer reviews, and I mentioned this earlier. There are 2 peer review opportunities, right? One is you're comparing your historical data to itself. So that's peer 1. Peer 2 is where I'm going to compare data to QC data. So let me make sure I'm saying that. Your QC data, and we look at QC within the same lot numbers from other organizations. So no issues at all. No, I mean, again, it's systematic. It's built in. It's a very easy process to navigate. Takes less than 10 seconds.
That sounds wonderful. Okay. And we'll wrap up our webinar with this last question today. This last question is asking, can you explain how bedside scanning and FlexLink integration specifically prevent sample mislabeling?
Oh, sure, absolutely. So when you're at the bedside, you go in to obtain a sample, you introduce yourself to the patient, you have two patient identifiers that you have to question, right? And so you question those two, and you have that order in your hand. Number one, you're establishing at that moment that you have the right patient with that order in your hand, because you've just validated those two patient sample identifiers. Number two, whenever you scan the safe pico syringe, you are tagging that syringe at that moment with that information you just validated. Number three, you entered the data into the FlexLink system. You've entered the settings, so you're reducing pre-analytical errors, guesswork on the back end. So you obtain your sample, you've labeled it with your sticker, but you've also labeled it with your barcode scanner. You put it in your biohazard bag and you go back to your analyzer, and at the moment you put that sample into the FlexLink tray, it pulls up the data. It pulls up the information that you entered when you were up in ICU or you were in the nursery, wherever you were. So that's how it prevents patient sample mix-up, because you may mess up on a sticker and say, oops, I put the wrong sticker on there. But whenever you scan the barcode at the bedside and you check your two patient identifiers, you just eliminated the biggest cause for misreporting. And again, I can attest to this firsthand. The number of patient sample mix-ups, we used to do, I'll just say this, we had more than we should have. And with this new system, it is awesome. It doesn't happen. And it doesn't happen because we're systematic in our processes of checking patients, scanning syringes, and then again, validating once that sample, that syringe is placed back in the FlexLink tray. That's how it prevents patient sample mix-up. It's a beautiful system.
Sounds like it. Well, I want to thank you again for your time today and your important research. We would also like to thank LabRoots and our sponsor, Radiometer, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions submitted during the live and on demand that we did not have time for will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone.